Good evening, everyone. I'm Neeta Samaya, a sarcoma medical oncologist at MD Anderson. Thank you for being here today and supporting Sarcoma Oma. I'm sorry I'm not there in person this year, but wanted to make sure all of you get updated about the exciting work that is going on and what your funding from last year made possible. You will also get to hear from some of the doctors who are involved in the immunotherapy research efforts at MD Anderson. We started by studying the immune microenvironment in most of the common and some of the rarer sarcoma subtypes. We prioritized 8 subtypes based on their frequency and unmet medical need. Dr. Lazar's team created tissue microarrays with hundreds of patient samples from each of these subtypes. They put them in these cubes, and they're able to stain these cubes to identify the presence and type of immune cells in these tumors. This helps us understand what mechanisms of immune activation, of inhibition, of immune-mediated killing might be in play in each of these tumors. We then prioritize which immunotherapies might be best applicable for these sarcomas. Your funding helped accomplish part of this extensive immunophenotyping, and we have identified mechanisms that are helping us with our current clinical trials and also future trial designs. We now have 4 immunotherapy trials geared towards specific subtypes of sarcoma. And though this is fantastic that some of these modalities that harness the body's own immune system are showing promise, there is still a lot of work that is yet to be done before we can understand what immune cells are capable of attacking sarcomas and which ones might actually be facilitating tumor growth. Though there are some similarities with other sarcoma types, most of the sarcomas seem to be quite different than the common carcinomas. The study that I started last year with novel checkpoint inhibitors in sarcoma patients accrued very fast. We have partially closed enrollment to follow response outcomes and study the patient's blood and tumor samples to see what is in play in those that are benefiting and what is the mechanism of resistance in those that are not benefiting. We have identified alveolar soft part sarcoma, a rare sarcoma subtype for which there is no standard of care therapy, that actually respond very well to these checkpoint inhibitors. You will hear from Dr. Rowland about our upcoming study about bringing these immune therapies into an earlier line prior to surgery. We like to see if we can affect long-term outcome by potentiating the body's immune response against the sarcomas. We hope you will all share some of our enthusiasm for the research that is ongoing and appreciate that though we have long ways to go, each small finding brings us closer to our goal of curing patients. Thank you so much for your support.
So as we all know, about 13,000 sarcoma patients are diagnosed every year. Liposarcoma and undifferentiated pleomorphic sarcoma are the most common types. Right now in 2017, for patients with early stage disease, surgery is really the only effective means for cure. We use radiation and chemotherapy to try to reduce the risk of recurrence, but over the last 50 years, there's been some progress in this, but many patients still recur, so we need to do better. Solid tumors are composed of not just tumor cells, but a lot of other types of cells, including immune cells. And this is really important because we know that those cells either can promote tumor growth or try to kill it. A new line of therapy called immunotherapy uses the body's own immune system to try to fight the tumor. And this is really exciting because it's been approved in many other types of cancer, including melanoma, prostate cancer, and kidney cancer. Recently, immunotherapy has been used in patients with advanced and metastatic sarcoma, and we found that patients with liposarcoma and UPS, the undifferentiated pleomorphic sarcoma, had some benefit even in patients with advanced stage disease. So what we've done here at MD Anderson is we're getting ready to start a neoadjuvant trial with immunotherapy. What that means is that we're going to take patients with liposarcoma or UPS that have very early stage disease and give them immunotherapy up front and then assess for how well their tumor responds when they have surgery. Now, the endpoint for this trial will be pathologic response, and what that means is that we'll look at the surgical specimens and see how well the tumor has responded. With help from the Sarcoma Oma Foundation, we've been able to look at a historic cohort of our patients with UPS and see what the immune cell infiltrate was like, as well as what the pathologic response was to just radiation alone. And that's helped us to be able to decide what a good response level would be when we use combination immunotherapy. So for patients on this trial that are enrolled, they'll get sequential biopsies, including at the time of diagnosis and then in the middle of treatment. And what we'll do is once we figure out which patients responded and which ones didn't, we can go back and look at the molecular mechanisms and figure out why they did or did not respond when we compare them with patients that did and did not respond. We're going to be doing quality of life assessments to see what side effects are really important to patients. And these studies will be really important because they'll help guide the next step of immunotherapy to try to help maximize the benefit that our patients will get.